So much happens. There's just so much going on that very important stories often we lose track of. At the time that Donald Trump came into power and made good on his promise to keep American funds for American causes and started slashing the budgets of groups like USAID and so on. And now we move on to other things. We move on to the 49 or 59 Afrikaner voetsekkers and so on. And thank goodness that specialist reporting groups like in the health field, Bekasies and Spotlight, are keeping us up to date with these stories. And my next interview is prompted by one of those stories. Joined now by Sean Wasserman, who's an infectious diseases specialist based at Groote Schuur Hospital in Cape Town, with us via Zoom. Good afternoon, Sean. Thanks for making time for us.
Hi, John.
What is your study area which has been affected by withdrawal of funding?
Well, we work in tuberculosis. My specific study area is on trying to improve treatment for people with TB, but also other HIV-associated infections. The story that Jesse Copeland brilliantly covered in Ground Up and Spotlight was related to a clinical trial that we're doing in Cape Town and also in Haiti that is funded or has been funded by the National Institutes of Health in the United States, a federal funding agency that, for the listeners, fund a huge amount of global health research around the world, and has funded us in our area in HIV tuberculosis research, with leading to enormous medical advances over the last 5 decades. And our trial was specifically evaluating a shorter treatment regimen for people with drug susceptible tuberculosis, so the regular kind of tuberculosis. We were evaluating a regimen that aims to shorten treatment from 6 months, which is the standard treatment duration, to 3 months.
And
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 if this
and
was
and if you could get that right, Sean, that would be incredibly important because one of the
well, we
issues is
assume that.
people not staying on treatment.
I mean, a lot of potential benefits: less
Yeah.
contact with the healthcare system, less catastrophic cost to families and patients, and potentially better treatment adherence with better outcomes in TB, right? Um, and this was the trial that, at least for me and my group, was directly affected by the withdrawal of funding.
Does that mean, and I hope it doesn't mean this, that the trial comes to an end and whatever benefits might have been realized as a result of the trial concluding are lost?
Well, we're not sure. The trial is going into year 4 now. We've already enrolled almost 100 patients into it. And we are in negotiations with the NIH to try and see if we can continue the trial. I mean, what hasn't been communicated in writing and formally and officially, is that South Africa is not going to get funded. But informally, in meetings with them, they're very clear about this. South Africa is not going to see a cent of NIH money for the foreseeable future, and probably not for the duration of this administration. And we're trying to negotiate with them to divert the funds to Haiti. Now, in the notice that they released, that was reported on by Jesse in Ground Up, they said that all foreign sub-awards would be paused and potentially cancelled, and research should be renegotiated to be transitioned to a domestic site, which means to the United States. Obviously, you can't do research on tuberculosis in a low-burden country like the United States so easily. So it effectively shuts down our trial, and we trying to get funding to continue it.
So it's paused at the moment. What impact, if that pause continues for another month, another couple of months, while this is being sorted out, hopefully with a successful conclusion, does that significantly affect the the efficacy, the integrity of the trial?
Well, it affects the integrity of the trial because we might not be able to complete it, and you need a certain number of patients to show an effect, right, in a trial when you're comparing two different interventions. But the immediate concern is an ethical one, because there are patients that are already enrolled into this trial receiving experimental treatments. And if funding gets withdrawn, which it has, then we can't pay our staff to follow up and look after patients who have consented and volunteered to take part in a trial and now don't have care provided by that trial, for an experimental treatment regimen that they're on. And I mean, this clearly has ethical implications and it is a safety concern for our patients who we commit to look after. And I mean, you can imagine that it undermines trust in research, right? I mean, in
Yeah.
our community.
How do you deal with those ethical and safety concerns that you've expressed, Sean?
Well, I mean, as investigators, we have a primary responsibility and we are scrounging around for funding from any source that we can find to maintain our staff and to continue looking after our patients. In our specific situation, I've been able to do that for a few months, but we've got contingency plans, and we'll have to transition patients back into routine care at some point if we don't get funding to continue monitoring them, which is risky, but we think it will be okay.
So there is a safety concern, but the safety concern is relatively modest.
Yeah, I would say that. I mean, yes. I mean, patients. I mean, what will happen is patients will be transitioned from the experimental treatment onto the standard treatment, which means they'll just start again and get 6 months. So, say someone is on the experimental regimen, they've had 2 months of that. Well, they have no choice but to transition them onto the 6 month standard one. But that's not. I mean, that's not a good situation for an individual, right? I mean, so
No,
instead of
because
getting
I was talking about
they're getting
TB
AIDS.
treatment. I was talking about TB treatment last week, and I was being contacted by people who have undergone or undergoing TB treatment, and it's not a pretty experience. So
No,
to
it's
to
not
to
easy to
go,
take.
I thought I was going to have 3 months. Now I'm looking at 8 months. I'm not sure I want this.
Exactly. And, people did not consent to this scenario when they joined our trial. There's not an expectation that the funder will, without explanation, withdraw funding and support in the middle of a trial. It's unprecedented.
I know that researchers don't like to try and look ahead to the results of the trial before the trial is concluded and the data, the evidence has been analysed. But I doubt that you would have started this trial if you didn't have some positive sense that it might lead to evidence that suggests you can safely and productively treat people for 3 months and don't need to do it for 6 months.
There are many studies now ongoing around the world trying to answer this question. This is probably one of the most important questions in the field of tuberculosis right now, at least drug-sensitive tuberculosis. How can we shorten treatment from 6 months? There already is evidence that 4 months of treatment is as effective as 6 months using a different regimen. This is already in WHO guidelines, except it includes a drug that isn't easily accessible, at least in South Africa, and actually is very poorly tolerated. And so it hasn't been implemented. And so the search is on for better tolerated, shorter treatment for TB. You're right. I can't tell you about interim results, firstly, because I'm blinded to them, which is what we do, right? I mean, we don't want to be biased by getting a kind of early look. So I can't tell you, and I don't want to tell you, even if I could, how our trial is doing. But you don't start a trial unless there is preliminary data to suggest that the intervention that you're testing has a good chance of working. And we were hopeful that it would be successful, or have a signal that it could be successful.
Well, let's hope that some money comes available very, very soon and you can get back on this track. Thank you so much to Sean Wasserman, who is, I'm just looking for the full bio, a consultant and reader in infectious diseases at St George's University of London, also an adjunct associate professor in the Department of Medicine at UCT.